Are you able to see the screen?
Yes, sir.
Okay. So the principles of regional anesthesia in children. First thing is anatomical differences between the older patients and the pediatric patient. Central nervous system. This chart is given in the World Federation of Society of Anesthesia tutorial of the week. The topic itself is given like this, and I picked up this question only from there. And all of you, are you all aware of the WFSA, TOTW articles that are coming in the net?
Yes, sir.
Please go through them on and off. They are publishing these articles every 15 days. And sometimes you may get your questions from that, and then it will be easy to answer that. So the main thing with the central nervous system effect here, we are worried about the neonate and the 12-month-old child. So the pediatric thing comes, but just to understand, they have given the adult values also. The spinal cord terminates, as you know, the neonate at a very lower level, L3, L4. After at about 12 months of age, it goes to L1 level like an adult. So it is safer to perform a Wernicke block at L3, L4 space in an older child compared to the neonate. So in neonate, you can go as low as possible below L4 and L5 or L5 and S1 rather than L3 and L4. If you want to do a single shot spinal, SAB should be done below the level of L4. And termination of the sac is also little lower because of the extent of the spinal cord at S3, S4, whereas it goes to S2, S2 in older children and adults. Now coming to the bone, the identical, the Taffius line, which we normally choose for the adult identification of the lumbar interspace. In adult, it is, all of you know, it is L4 and L5. That is the two imaginary line between the highest points of iliac crest is called the Taffius line. And here it is at the L5S1 level, which is at a little lower level. And curvature of the spine is also different. Vertebra, they are more cartilaginous, whereas it becomes bony and ossified later on. And sacral vertebra, they are all incompletely fused. And that is the reason why you are able to do the caudal sacral epidural very easily in these patients. And continuation of that, epidural fat and ligaments and volume are all different. What she mentioned about that. So the volume is larger in both neonates and older children. It is about 50% compared to the 25% in the spinal area for an adult. So that is the reason why your local anesthetic will be very much diluted by the larger volume of CSF, and that is the reason why you have to give per segment volume will be more than you give for pediatric patients as a Wernicke block. And peripheral nervous system, the myelination, the endoneurium, vasculature are all different between the neonate and the older children. So myelination is not complete until the child is of 12 years age. Okay? Then only it gets completed. And the endoneurium is loose, so the drug will be easily taken up. And because of the wrist vascularity, they will also be removed faster. So the onset will be faster, and recovery also will be faster because of the vascularity. So here you can see LA gets absorbed quickly away from the nerves, resulting in a shorter duration. And the onset is much more faster because of the loose absorbed quickly away from the nerves also. Then, as they said, after the anatomy, you go for the pharmacology of the local anesthetic, how they differ in the action in the pediatric compared to the neonate and older children. So absorption, distribution, metabolism, and clearance, ADM excretion. And clearance of after a continuous infusion, all are pretty different from the older children. And apart from this, the enzymatic immaturity. So enzymes are not well developed, and because of the increase in ECF and low plasma proteins, they also cause more free fraction of the drug to be available. That is why you have to be very, very watchful with the dosage that you give. And increased cardiac output and heart rate leads to increased absorption of the drug from the site where you inject. Sympathetic immaturity, diminished autonomic nervous system adaptability, and small vascular bed in the lower limbs, all of them are all another reasons for the difference. And delayed acquisition of body steam and anxiety also is another reason for the changes that happen. Now, what is the maximum dose of various drugs that we use? We should have a good idea about it. So for bupivacaine, it is 3 mg per kg, which is almost like your normal adult patient. For 4 months to 1 year, 0.25 for infusion rate and 0.35, 0.4. Bupivacaine, again 2 milligram per kg maximum total use. Levobupivacaine 3. So bupivacaine and levobupivacaine, because they are more cardiostable drugs with less effect on the cardiovascular system, you can use a little higher dosage. Lidocaine 5 milligram and 7 milligram with adrenaline 10 milligram is recommended. And perception of pain in pediatric patients. This is another point that we have to discuss is C fibers are fully functional from early fetal life itself. Earlier, they were all thinking that neonates do not perceive pain because C fibers are not fully developed. The earlier concept was that you can do anything with the neonate, and in fact, during our postgraduate days, whenever we want to induce a patient for pyloric stenosis or other tracheoesophageal fistula, we used to, because they are all, they don't have muscle power, we used to just like that put the straight blade and intubate them in a completely awake state. That was what we were taught. Then later on, papers started coming saying that by doing this, you are producing a lot of stress and intraventricular hemorrhage can happen in the babies, especially in the neonates. So then the concept changed and they said that the neonates also can perceive pain like any other person. So the proof that is C fibers are fully functional from fetal life. Slow or true pain is conveyed by these unmyelinated C fibers. It leads to protective reflexes like autonomic reactions, muscle contraction, and rigidity. And the connections between C fibers and dorsal horns are not mature before the second phase of postnasal life. That is the only problem. Substance P receptors decrease during the first 2 weeks of life, and inhibitory control pathway, which are immature at birth, develop concomitantly. So these two things are the protective mechanisms that develop. And when analgesic agents are administered before painful procedure, that is preemptive analgesia, if you give, infants demonstrate less evidence of procedural pain. So even before an IV puncture, to secure an IV line, if some analgesic has been given orally, that causes less stimulation in the children. And the long-term behavior also changes, or it's not affected by this nociceptive stimuli. And inability of young patients to communicate and express their distress or discomfort is another hurdle in managing their pain. So age-related pain scales are formed to overcome this in pediatric patients, especially when you use regional technique. You must know that block is adequately taken effect before you allow the surgeon to perform or touch the patient. So coming to the pharmacology of local anesthetic and additives, because of the immature enzyme pathways and progressive increase in body surface as the child grows, it affects the pharmacology. How it affects is the practice is not calculated on the but we still calculate the drug dosage based on the body weight only. And the LA drugs have a faster onset of action, higher spread, shorter duration of action, as we all saw earlier. And systemic absorption and distribution is influenced by plasma protein binding, uh, redemption storage, absorption from epidural space, hepatic extraction and clearance and metabolism, elimination, half-life, and systemic toxicity. All these factors determine the LA toxicity effect. And additives, we can use opioids, epinephrine, clonidine, ketamine. That is preservative-free ketamine is also recommended. Dexamethasone and midazolam. These 6 drugs have been added as additives to prolong the block duration and quality in pediatric patients, which is officially recommended. And physiological factors are the central neuraxial blockade are virtually free from measurable hemodynamic. That is, they don't get a sudden hypotension or a bradycardia up to 8 years of age. So subarachnoid blocks are quite safe in these patients. And there is no need for preloading with crystalloids as we do for adults, or using vasoactive drugs are very rarely needed in these patients. Now, psychological factors, fear of new environment. That is, in older children, there is separation anxiety, stranger anxiety, and needle phobia. All these are quite common to perform your regional technique in a conscious patient. So that is the reason why majority of the time we always try to sedate them or give them some ketamine to perform any regional technique in these patients. Now coming to indications, contraindications and other problems. Indications are intra and post-op analgesia or procedural pain, you can use them. And non-surgical pain like chronic and palliative care, you can use regional techniques, especially children with congenital carcinomas or blastomas and other tumors and other overall pain. You can use them as a chronic pain relief measure. And for non-analgesic indications, and indications are coagulopathy, any active infection through allergy and hydrocephalus, or cranial tumors, use of chemotherapeutic agents, uncorrected hypovolemia, and other things are all contraindications. And parents' refusal is a very important non-medical legal critical contraindication. This if parents say don't want to have any regional done in my child, then you cannot do that. Risk of compartmental syndrome, hemoglobinopathies like sickle cell are pre-existing neurological disorders. I think you are not correct in saying that you can do local blocks or regional technique in neurological disorders is also contraindication. Coming to complications, nerve damage by the needle, tissue coring or deposition in epidural space in intraepidural, injection of neurotoxic solutions, leakage around the puncture site. And systemic complications, last, that is local anesthetic systemic toxicity due to accidental IV injection or overdosage. And the difference between adult and pediatric is both CVS and CNS symptoms appear together or concomitantly. Now, selection of materials, technique, and agents. You have various options. You can use a single shot technique either with a short acting or a long acting drug. You can use a single shot technique with local anesthetic and adjuvants to prolong the block. You can use catheter techniques for repeated or continuous analgesia for longer procedures. What is the equipment and technique needed? CSF hydrostatic pressure is low, so advance needle slowly when attempting spinal in infants. Loss of resistance to saline is better than air since ligaments are very soft. And peripheral nerves are very superficial, so surface mapping can be done with a low current needle locator, nerve locator. Small probes, also called jockey stick, should be available to locate the nerves. Ultrasound guidance is able to show spinal cord clearly in neonates and infants due to poor mineralization. And acoustic device, electrostimulation are alternate methods to identify the epidural space in pediatric patients. Now, selection of anesthetic solution depends on site and severity of surgery, expected duration of intense post-op pain, daycare versus inpatient in hospital patients. Most LA blocks in pediatric patients are done for analgesia rather than for anesthesia. So, how to perform this block awake versus anesthetized patient? Older patients to whom you can talk and convince them, you can do it in an awake state. Majority of regional anesthesia are done under sedation with ketamine or under GA. Inhalational volatile agents also, as they may not cooperate except older children who can be counseled. Now, what are the common neuraxial blocks that are performed? We can perform caudal very frequently, intervertebral epidural, spinal subarachnoid block. These are the three central neuraxial blockades. Upper limb blocks, brachial plexus block above the clavicle or below the clavicle. Lower limb blocks, lumbar plexus block, femoral nerve and fascia iliaca compartment block, saphenous nerve block, lateral cutaneous nerve block for any skin graft, operator nerve block, sciatic nerve block, popliteal block, metatarsal block. All these lower limb blocks are performed. Truncal blocks, today they perform thoracic paravertebral, rectus sheath, periumbilical block, ilioinguinal or iliohypogastric for hernia, pudendal nerve block, penile block for condition. All these are truncal blocks. Head and nerve block, laryngeal nerve block, stellate ganglion block, supraorbital, mental, all these mostly for pain relief, not for a surgical procedure. And local anesthetic and topical application, you can apply surface application of Embla cream and the topical sprays are commonly used. And local infiltration and field block for surgical use. And what are the basic safety recommendations for any type of regional or LA to avoid medical legal claims in these patients is thorough pre-op evaluation by examination of the patient physically, the needed investigations by lab, radiological or other methods. Select the least hazardous technique and give the explain the merits and demerits of these and the complications to the attenders or caregivers or patients, even in emergency cases. Possibility of block failure and alternate plans to be discussed with the parents. Obtain recent informed consent. All standard monitors recommended for the procedure to be used. Fill in the anesthesia chart with details of monitors used, vital parameters before starting the block at intra and post-op, technique and doses used and adverse effects if any. Treat all complications and document full details with precise timings. That is very, very important. Transfer patient to post-anesthetic care unit, continue monitoring, till the recovery from block, maintain post-anesthesia chart, and plan discharge when objective criteria are met, like patient should be moving all the four limbs, should be awake, should have voided, all these criteria which we normally follow. And if additives like morphine or other drugs are used in epidural, overnight admission and monitoring for delayed respiratory depression by monitoring for every 1 hour during first 6 hours and every 2 hours for next 18 hours is mandatory. Okay. So these are all the things that you have to mention for principles of regional anesthesia in pediatric patients. So starting with the